morning. I know everyone is very excited to be back in person, so it's great to hear buzz in the room. And welcome to the annual meeting of SPR in Seattle in person. I'm Supplee. I've had the privilege of serving on the SPR board for the last 3 years, and was able to plan this plenary along with my co-presenter, Ruben, Parra-Cardona, who is unable to join us here today. I'm kicking off this plenary with an amazing opportunity to come together around prevention science. We at Prevention Science want to acknowledge that our annual conference is being held on Indigenous lands. These ancestral homelands have been the traditional territories of the Duwamish, Suquamish, Suquamish, Puyallup, and as well as the tribes of the Muckleshoot, Tulalip, and other Coast Salish peoples and their descendants since the time immemorial and into the present day. We are grateful to have the opportunity to meet here as guests on these lands with the Coast Salish and Native peoples who call this home. This land acknowledgement is one small act in the ongoing process of working to be in good relationship with the land and people of this land. Before I introduce the plenary, there are a few special events that I want to draw your attention to, including the other plenaries and invited talks on Thursday and Friday. There are also a couple of events specific to SPR as an organization, including there are 2 special interest group meetings at noon to 1 today and then repeating again on Thursday that highlight the progress on our current strategic plan and provide opportunities for our members and attendees to provide input on new directions for our new strategic plan. So please join us at those conversations. Second, there is a membership business meeting, which is a new-ish event. We did one virtually last year, but this is the first time in person. That'll be held Friday from 8 to 8:30 a.m., where we'll update members on our 2022 conference registration, our membership numbers, and the plans for the 2023. We would love to hear from you on both of these topics. Finally, the plenaries, invited talks, and a few of the other events are being live streamed. Welcome to those online. Please remember to tweet with the hashtag SPRCon22, both here and online. Now for this morning's plenary. So the title of today's plenary is Centering Equity, Dissemination, and Prevention Science. What does it mean? How to achieve it? The field has grown exponentially, leading to historical breakthroughs in prevention alternatives that have resulted in improved public health and well-being, including the reduction of health and mental health inequities experienced by diverse conditions. But the field continues to be presented with challenges that only a small proportion of evidence-based interventions, including best prevention practices and policies, ever reach the population of highest need. Our panel today will discuss a framework for thinking about equity implementation, along with an example of what equitable implementation looks like, followed by a funder who's considering how to support equitable implementation. As with the plenaries, there'll be no time for Q&A during this session, but we invite you to join us at the roundtable following that dig deeper into issues. Our 3 speakers today are Rachel Shelton, who's an associate professor at Columbia University, and Mailman School of Health, Department of Socio-Medical Sciences, and co-director of the Community Engagement for Research and director of Implementation Science Initiative at Columbia's Urban Institute of Clinical and Translational Research. Second, Linda Callejas,
The only thing that's on is the podium.
University of South Florida,
Check your mic.
Department. And then joining us virtually online will be Cheryl and Boyce, who is the assistant director for the re-engineering of research enterprise at the Common Fund Office of the Director of the Army.
Now, without further ado, I will turn the mic over to Rachel Shelton.
It's not showing. Oh, there. Getting used to the being back in person and all the technology. Thanks so much, Lauren. So good to be here. This is actually my first SPR conference, and I'm thrilled to be here, and especially in person. And for those of you who are remote, it's very, very exciting to see old friends and colleagues again. So I was really asked today to think about kind of setting the stage in terms of what it can mean in terms of centering equity in implementation science, or D&I science, as we sometimes call it, dissemination and implementation. And specifically, I was asked to really put forth some of the ideas and work that I have done with colleagues on really an anti-racism frame in implementation science. So that will be the focus of my talk today. I think it's really important, first, just to get some kind of foundational grounding in terms of what we mean by health equity. I've been doing health disparities cancer work for about 15 years now. And there's been a really notable shift in the language we use in the last couple of years. And I think this shift is not just semantic. There's really been a focus on how can we actively promote health equity. And I think there's a distinction here in that a focus on health equity really recognizes the injustice and the unfairness of health inequities. And it also names and recognizes the underlying structural and social inequalities, things like housing, things like education, things like racism and discrimination. All of those things that are underlying and shaping those health inequities. I also love this definition here on the right by APA, which also recognizes that because of these historical injustices, not everyone, not all groups in our society are at the same starting place. And they require different groups because of that require different resources, different approaches, different interventions. It's not a one size fits all approach. And I love this notion that it's an ongoing process, right? It requires reflection and accountability for all of us. And, you know, my work again is mostly in the space of cancer prevention and control in the US context and racial inequities. But for all of you, your work will be different based on the populations and settings you work with and your own background and what you bring to that. So hopefully this talk today will have you reflect and think about what health equity means in your own work. So, you know, my work in implementation science started about 10 years ago. And you would think that health equity and implementation science are a nice match, right? Implementation science developed over the past 20 years in recognition of the very well documented gap between research, all our evidence-based interventions, and practice, what's actually routinely delivered in most real world public health and clinical settings. But I put equitable there in a paragraph because even though we know that the inequities are part of the reason we have that research to practice gap, all of those structural factors, all those social factors are shaping that gap. We have not historically always named that focus on equity. So a lot of my work now, you know, when I first started in the field was really focused on social epidemiology, understanding the impact of discrimination on cancer outcomes, thinking about community engaged research. And I came to implementation science around 2009, 2010, as the field was developing, because I saw the tremendous potential that the field has in terms of, again, really being able to take action and think about how we're addressing that gap that is shaped by inequities. I was asked a couple of years ago by NCI to do kind of a review of all the literature on equity and context. And it was really interesting. I found that, you know, equity and context were kind of everywhere and nowhere. So a lot of times we were really implicit. Many of us came to the field of implementation science because we saw this promise that it has. But when you actually look at a lot of the interventions, the strategies, the frameworks, the theories, and the methods we're using, equity has not necessarily been explicit. So a lot of my work now is really encouraging us to reflect and think about if we really want to have equitable impact at scale through implementation science, we need to make sure we're having a focus on meaningful engagement, health equity, and equitable implementation in all these key domains of the field. I think it's important to recognize there has been a long history of work on racism and health. You know, David Williams, Kamara Jones, there are numerous scholars who have focused their careers on this. And it's important to note that there is a distinction between social determinants of health, things like housing, things like the criminal justice system, things like education. We've tended to focus in public health and healthcare on addressing social determinants of health, particularly in the last 5 years, we've seen the shift towards that. And I think we also have to recognize that structural racism is a system that it underlines and shapes those social determinants of health, right? It's not an additional social determinant of health. It's a system that shapes the inequitable distribution of those determinants, of opportunities, of power and resource. So again, that's another shift, important shift that I think we're seeing in the field. Together with April O at NCI and Projecta Ad Sul, we wrote a piece a couple of years ago, which again made the case that if we truly want to make shifts, not just chip away at our health disparities, but truly make some fundamental shifts towards health equity, we have to be actually naming and thinking about how we're addressing structural racism as a fundamental driver of social and health inequities. So we wrote this piece, and then the piece I'm going to talk about today was kind of our follow-up piece of how can we think about taking action. So a lot of people ask me, so what does structural racism have to do with implementation? And I think it has a lot to do with implementation in our research. Racism is a fundamental aspect of social context. If we think about all of our institutions, all the research we conduct, all the partnerships we have, that historical context, that ongoing context is a critical part of it. And it advantages some and disadvantages others. It also operates, again, it's an adaptive system. It operates within and across interconnected systems through policies and practices. So it shapes and reinforces both health inequities and the research practice gap. So if we think about something like residential segregation and redlining and the history of that, it has implications not only for creating the inequities, the health inequities in mental health or physical health, it also has implications for which settings and populations have access to quality care in their neighborhoods and have access to the evidence-based interventions that we're talking about here today. So not thinking about, ignoring the role of structural racism really has some really fundamental implications because it leads to inaccurate explanations of why health inequities exist and persist. And it also has implications for how the solutions and the strategies and the interventions we select to address it. So it's fundamental that we consider it as part of context. So in this piece, I'm going to direct you to, I want to highlight my co-authors here. This was really very much a team paper with Projecta Ad Sul, April O, Natalie Boyce, and Derek Griffith. And Derek Griffith leads a Racial Justice Institute at Georgetown University, and he has been doing work on anti-racism frameworks for about 15 to 20 years. So our team over the past over 2 years met and sat down together and thought, what would it look like if we were to bring an anti-racism focus on our implementation research? What would that mean? So I'm going to go through some of these core elements. And our idea here was, it's not enough to name structural racism. That's the first step, to think about that structural analysis. But then what are we doing? How is that actually informing our action, our selection of strategies, our selection of interventions, our frameworks? How are we making that connection in terms of how we're then dismantling or mitigating the impact of racism? So I'm going to go through some of these quickly, and I'm going to refer you to this paper if you're interested for a much more detailed kind of guidance on recommendations and reflection questions. So first, in terms of community engagement, I see community engagement and health equity as going hand in hand. It is essential to a focus on health equity and anti-racism. And it's important to recognize that where we often come in implementation science, there's often a disconnect, right? It is not a surprise sometimes that we're not able to implement and sustain evidence-based interventions if we have not focused on health equity from the start, right? If the populations and settings that are experiencing structural inequities aren't reflected as we're developing and testing our efficacy studies and our effectiveness studies, it's not a surprise that we're not able to implement and sustain once we get into those settings and, in the real world or the more real world settings. So I think that's critical. We have to be thinking about engagement early and often and equity early and often along this, this kind of a traditional translational pipeline. It can't be a tag on at the end. I'm not going to talk too much. I know Linda's going to talk a lot about community engagement. And I want to say, I think, community engagement on its own is not enough to address structural racism, but I do think it lays the foundation for creating structural change and promoting equity. And it creates the structures and processes through which community voices, those experiencing inequities, can be elevated in ways that we can incorporate their perspectives on solutions and priorities. So again, there's been lots and lots of amazing work for 30 plus years on CBPR. So I'm not going to go through that. There's wonderful resources. And there's been great examples in implementation science. The work of Ken Wells and Loretta Jones and others at UCLA have done some great work thinking about community partnered randomized control trials and really community engagement and the design and delivery of depression care as one example. And here's some work that Prajakta Atsul has done as well on this model in cancer prevention and control for sexual and gender diverse population. So there's lots and lots of examples. And in the context of implementation science, what does this look like? I think here, what sometimes is slightly different is our community and our stakeholders might be broader, right? They might be the community members, but they might also be the community organizations and those leaders. It might be the implementers, the practitioners, the policymakers. So we have to really think about who our community is in implementation efforts. And we have to really reflect on how we are engaging them, who is at the table and not, whose voices are heard and not, as we're determining our evidence-based interventions and our solutions, and as we're selecting those for implementation. So again, there's lots of amazing work that's going to be talked about this. But for me, I always think this is a great opportunity for us just to think about ways that we are able to support this work that isn't grant funded as well. We have to think about moving beyond a lot of the traditional research funds that don't necessarily support this work. And hopefully we'll see shifts in NIH and other funding organizations to support this. But this is a challenge to do this work well, especially in terms of kind of resource sharing and sharing of data and sharing of funds. Okay. What about as we select and develop our evidence-based interventions? What does that mean when we think about a health equity and anti-racism focus? So I think it really requires that we step back. We often have our intervention, our program. We often show up. My community partners always remind me how disempowering it is when we kind of show up and say, we have this intervention, we're ready, we're here. And they, again, haven't been reflected in that or haven't been engaged in the selection. So we have to sometimes step back and ask ourselves, has the intervention been found to be effective in addressing inequities? Is it been looked at among the population we're working with? Does it address any of the social determinants of health or structural determinants that we know are some of the root causes? Does it work at some of these more upstream levels? And does it build off of community strengths and recognize some of the social cultural contexts and values of the partners we're working with? A recent paper that I co-authored with Ross Brownson and Russ Glasgow and Elvin Ging really encourages us again to think about what we're counting as evidence. We have historically had really an evidence hierarchy, and we've valued certain types of evidence through our randomized control trials. And I think we have to reevaluate that a little bit and think about new ways that we're defining and counting evidence. We really encourage people to kind of move beyond a lot of the traditional evidence-based intervention repositories that we have and think about practice-based evidence, think about community-defined evidence. Are there programs that are already being delivered in the settings and populations experiencing inequities that we can partner with and evaluate and think about its implementation and scale up? We also often focus a lot on the individual, interpersonal, and sometimes organizational levels, but we really need to think about building the evidence base for interventions that are going to address much more of these upstream factors, community level factors, a lot of the structural factors we're talking about. And we're not there yet, but here's an example of some of the amazing work that Zenza Bailey and colleagues have done on interventions to address structural racism. So we have to think about prioritizing some of these interventions that are non-traditional that we haven't tended to look at in implementation science. And also think about the settings, moving beyond just the focus on the trials in the healthcare settings, but you all do this work already in schools, in churches, in communities as well. There's lots of great examples of frameworks in implementation science. I won't go through these in too much detail, but just to think, there's lots of ways we can think about designing for dissemination, using co-creation with community partners to think about implementation upfront as we're developing and testing our interventions. There's great work on user-centered design and human-centered design that we can think about to kind of refine and tailor to the setting and population. So again, a lot of work needed in this area and a lot of tools and resources as well. I'd also encourage us to think about the types of adaptations that we can make to our interventions to really enhance the cultural and contextual fit. And again, we have not built an evidence base in terms of which types of adaptations matter in terms of addressing or reducing inequities or exacerbating them. And I think we have opportunities to think about how we're also adapting our interventions to address social determinants of health as well. For our theories, models, and frameworks, again, in implementation science, we love our multi-level contextual frameworks, and we often start with a contextual assessment. But often, as we've done this work, we've focused a lot on organizational context, and we've really left out community context and social context. So we have to ask ourselves, are the determinants that we know matter for health inequities, things like stigma, discrimination, and racism, are those reflected in our frameworks? And if not, how can we adapt or refine to make sure that we're capturing that? How are we thinking about the mechanisms through which structural racism might shape institutional policies and reinforce racist practices? We've seen this with clinical algorithms and some of the assumptions behind that. So I think we have a lot of ways we can think about refining our frameworks to make sure they're actually capturing the equity components that we know matter. And again, in implementation science, we've seen some real growth in this area, the health equity implementation framework by Woodward and colleagues, some great work thinking about the mechanisms through which power operates in implementation. So I will direct you to those, but again, a really important and growing area. And one piece I just love is work by Michelle Allen and colleagues, where they've taken the consolidated framework for implementation research, which is a common multi-level framework, and really brought a racism conscious lens to it to think about how it is operating at different levels. So I love this piece. It's in ethnicity and disease, and it's a great example of what it would mean to bring a racism conscious approach to some of our frameworks. I'm running out of time, so I'm going to go through this quickly. And we have Byron Powell over here, who, has done a lot of amazing work thinking about implementation strategies, all the, how we can get our evidence-based interventions into practice. And I think we have an opportunity to also think about, are there certain strategies that might exacerbate or reduce inequity? So things like anti-racism training, strategies that build cultural and structural competency, strategies that enhance ownership and build capacity. These might be ones that we could test with an eye towards equity. There's an amazing example, the ACCURE trial in North Carolina, where they actually did a pragmatic quality improvement trial to try and address racial inequities in cancer treatment between Black and white patients. And they used these 3 implementation strategies: an anti-racism health equity training for staff and providers and administrators, a real-time race-specific electronic health registry to signal unmet care when someone wasn't referred for chemo, and then also clinical feedback and connection with a navigator to address some of the social determinants. And they completely eliminated the racial inequities through this approach. So this is a nice example of what it can look like to apply strategies that are actually addressing some of the institutional forms of racism. I'm going to skip that. But I just want to say that there's lots of questions and thinking about strategies that I think are wide open. This is an area that we really have only begun to think about. Finally, with our methods and evaluation with an equity lens, I think, again, in implementation science, we think about things like reach and adoption and implementation and fidelity, but only recently are we thinking about the extent to which there's equitable implementation, right? Equitable reach, equitable sustainability. In my work, I've partnered with David Chambers and Russ Glasgow to think about how can we have a greater focus on equity and sustainability from the start in the re-aim planning and evaluation framework. So usually we kind of get to the end, we see that there are inequities. How can we be really explicit in tracking when and where the inequities are arising, whether it's in the setting, whether it's with respect to the population, and then thinking about what are the adaptations that are needed to address that inequity. So again, I direct you to this paper that has a lot more detail, but we hope that this is a tool that people can use to bring a greater explicit focus on equity. And I am going to skip this and wrap things up. So I just want to end by saying, I think this is an area that to me is so, so important. In my work, the reason that I came to the field was really this group of amazing cancer survivors and lay health advisors that I started partnering with. And I think this is us in 2009 when we got our first NCI grant together. And I came to the field of implementation science because they had lost about half of their programs nationally. They had 40 programs that were kind of this peer lay health advisor program, and they had lost half of them due to the economic downturn. So they said, let's partner, but we only want to partner if we can study how to sustain and support our program. So this was really important to me because I knew that this work would have real impact in terms of its translation. So again, that's what got me into the field of implementation science. And now, 12 years later, 13 years later, we're still partnering and we're co-creating frameworks together that reflect their experiences of things like structural and institutional racism, their experiences of medical mistrust, and their experiences of not feeling like guidelines reflect their lived experience of having more aggressive tumors at younger ages. So for me, it has been just a tremendous partnership and really had me reflect on ways that I can be more explicit in my work and sharing their experiences and their experiences in terms of how we can do better in our research with an eye towards health equity. So I just want to thank you all. I think that there is so much amazing work to do. And I'd encourage us all, again, just to reflect on how this comes into play in our own work. How are we being accountable? How are we reflecting on how health equity shows up in our work or not? How are we making sure we're not exacerbating inequities through our implementation science, through frameworks that don't reflect equity, or through only including settings that are more resourced, right? So how are we being accountable and thinking about how this plays out in our own work? I will direct you to some amazing resources if you're interested. Chandra Ford and colleagues have a book on racism and public health that is just amazing. And there's a lot of work being done as well, thinking about institutional change and change among funders and in our institutions that's needed to complement the focus on research. So thank you so much. An honor to be here, and I'll hand it over to Linda.
Good morning, everyone. Let's see if I can find my presentation. This is also my first SPR meeting, and I'm really excited to be here with all of you today. I can't get this one off. I should. Okay. Sorry about that. All right. So I'm really excited to be coming off after Rachel's presentation, which really talks about some of the questions of equity and community-defined evidence. I'm going to be talking about some practical examples from projects that I've worked on. The community-defined evidence project first, then I'll go over a health promotion program, Bienvenido, that was one of the practices that we looked at in this community-defined evidence project, and just some quick reflections from a current participatory evaluation that I lead in Miami-Dade County, Florida's child welfare system. Excuse me. And I'm hoping that these examples will outline some of these key questions of how we have looked at these practical applications of these questions discussed, right? So before I begin, I wanted to highlight three basic assumptions that underlie my discussion today and much of the work that I do in this area with regards to behavioral health. And the first is that even though we are making a lot of great strides, as Rachel noted, much of the work that we continue to do, particularly in implementation science, is researcher initiated. And that leaves us in a place that centers the researcher expert, right? And does not really look at communities as co-creators, not just of interventions, but of knowledge, right? So that then this leads me to the second assumption in my work, which is to kind of try to disrupt this. As anthropologist Jonathan Rosa notes, communities are sites of knowledge production in and of themselves, and there are rich sites of knowledge production if we take the time to really get to know communities and that sort of knowledge that they bring, right? And that the third is that genuine collaboration requires us to really acknowledge these power imbalances that kind of blind us to this knowledge and all of the rich information that communities bring with their own traditions and ways of knowing. And so it's up to us to really reconfigure those power imbalances. So I'm going to start, as I said, with the Community Defined Evidence Project. To give an example, it's kind of an overview. And then when I talk about Bienvenido, it will give some more of the detail about these types of programs that we looked at. This applied study was conceived in 2006 when members of the National Latino Behavioral Health Association initiated discussions with funders and policymakers to discuss the need to better understand how mental health practitioners were responding to persistent behavioral health disparities, particularly in Latinx Hispanic communities around the country, right? And they raised a number of concerns during these discussions that we just heard about with regards to the ability of evidence-based practices to get to the communities that need them, or even the idea that evidence-based practices were going to sort of solve this question of disparities and inequities. And as part of that discussion, what ends up happening is that the SAMHSA, Substance Abuse and Mental Health Services Administration, and the Annie Casey Foundation decide to jointly fund as an applied initiative this study, which these were basically our study aims, right, which question the primacy of the evidence-based practice movement and the restrictive nature of its epistemology or worldview about what constitutes evidence, as Rachel noted. So we question whether relying on the evidence-based practice movement was culturally appropriate, particularly since this definition really excluded, we thought, indigenous ways of knowing and other forms of evidence that were out there. And so this gave us the opportunity to really think about applied findings to these questions. Okay, nope. All right, so these were our key study questions. We wanted to identify community-based and or culturally focused practices that work for Latinx Hispanic communities. And we wanted to learn more about how community members, providers, but also service recipients know that those practices work. We were interested in identifying essential elements across these practices to learn more about their core implementation components and what organizations and providers had to do to support their successful implementation. And finally, we wanted to learn more about how the development, implementation, and evaluation of these practices involved community members and service recipients in particular. So this slide provides a quick snapshot of the organizations that we included in the study. And you can see that although we did include at least one organization from the states that have long been recognized as having large Latinx populations like New York and California, we also tried to make sure that we talked with folks. We had representation in the Midwest, the Pacific Northwest, and elsewhere. And for sampling purposes, we not only took geographic distribution into account, but we did look at the practices or interventions themselves to get a wider breadth. So we did qualitative research for this project. We categorize the interventions that we found through, and I'm not sure, I think I might have skipped a slide, but basically we conducted about 240 interviews at these organizations where we talked with service providers, service recipients, community partners, which were very integral to most of these interventions and programs, and family members or caregivers of service recipients. So we really did try to do a deep dive and do in-depth interviews with those folks. We we talked to 240 people at 15 different organizations. And then we analyzed all of those interviews. And so this was sort of the categorization of the practices that we examined. We found interventions that focus specifically on heritage or cultural identity as integral to health and healing in those interventions. We also looked at mental health promotion and anti-stigma programs that really focused on culturally relevant ways of increasing awareness and removing stigma. Intensive or focused outreach and service delivery like promotores de salud type of programs, culturally focused engagement strategies, and indigenous practices and interventions. And we also looked at just a couple of local adaptations of evidence-based practices for the local Latinx communities. So the essential elements, what we try to do, a lot of these interventions were very different in their own way, but we tried to really distill what the core elements, particularly for healing and what service recipients said were really important to them. So the first of these was that pretty much all of these interventions really address mental health as part of a larger constellation of holistic health and well-being, right? And that the way that mental health was discussed was much different than what we typically find in formal provider or organizations or clinics. The second was the centrality of the family and acknowledging the importance of the family, but also including a lot of times family members and service recipients in service delivery whenever that was appropriate or possible. And then this third one was really critical for so many service recipients, that many of these interventions were delivered in collective ways where people come together in drumming circles, in discussion groups, and really get a chance to sit with others and discuss their distress, but also their healing and the power of their own practices and beliefs that help them to feel better. Again, the affirmation of traditional beliefs, cultural practices was critical to all of these interventions. And even though that was manifested in very different ways. And then many of them also had a component of getting folks connected in their communities, increasing social support networks outside of the family for folks that didn't have family members readily available, but also to just get them integrados into the community. So that was really another important aspect. We also were really interested in learning about what organizations did to support successful use of these practices with these populations that they served, right? So one of the things that we found was just about all of these organizations were very flexible in their ability to address and respond to changing community conditions. So for instance, a few organizations that served immigrant populations in particular would change their service delivery hours, let's say, to have folks that were undocumented avoid being out when there were raids going on, right? So that was one key way that we found that organizations responded to conditions on the community to support the people that they serve. The other, as I said, was community partnership. Most of these organizations, some of them were grassroots and emerged not as mental health providers, but eventually became mental health service providers, but others worked a lot with communities across the, organizations across the community that were important to the people that they serve. So ethnic specific organizations, churches, schools, but also restaurants, laundromats, places where people were and were readily available. The other thing that we saw was that within each organization, there was usually one champion or key figure that was the sort of the person pushing forward these community defined practices and making sure that in the organization, for some of these organizations, these were not, ethnic specific or embedded in the community, but they were the example of Bienvenido that you'll see was a mental health clinic, right? A traditional mental health clinic in an area with a growing Latinx population, but almost no staff to serve that population. And that in this organization and as in others, there is a champion or key figure that's pushing forward the importance of these interventions or programs and their necessity for the betterment, not just of the community, but of the organization itself. And then what we often saw as well was that the organizations and their leadership, as they began to really promote these practices, become leaders in and of themselves and advocates in their communities, in the service systems they're involved in, and in, at statewide level, talking with funders, talking with policymakers about the real importance of these types of programs and interventions. So I'm gonna shift over to look at the Bienvenido program. I wish I could do more of a deep dive on all the different programs we talked to, because there was a lot of very interesting interventions. The Bienvenido program was founded by Gilberto Perez. And this, part of the presentation is gonna take from a paper that Gilberto and I and Francisco Limon published in a special issue of the Stanford Social Innovation Review looking at equitable implementation. And Francisco was an evaluator of a Bienvenido adaptation. So the Bienvenido program development process really begins in 2003 in this corner of Indiana, in Ligonier. Gilberto Perez at the time was a mental health therapist in the clinic called the Northeastern Center. And he was part of a small, longstanding Latinx, Mexican largely descent community in this part of Indiana. But since the late 1990s, there was a growth of immigrant populations coming in from Mexico and Central America due to the RV industry in the area, right? So this population is growing and growing by leaps and bounds. And so by 2003, Gilberto starts to notice that although there's a sizable population and there are some issues that he knows about, that he's concerned about with regard to behavioral health, and other leaders have started to identify, but they don't see people coming into the clinic at all, right? They don't see any of that, which is kind of a little bit typical. So what he decides to do is to work with local leaders and residents to establish a collaborative needs assessment process to really try to figure out what the needs are in the community and how they might be able to get help and support to the community members that need it. So this group works together to formulate assessment questions and helps staff from the mental health clinic where Gilberto worked to connect with community leaders and trusted organizations like schools, churches, and local big restaurants, really local restaurants, to engage local residents in assessment questions. Okay, so I'm gonna hurry up as time is flying. So one of the key things that they did once they got the needs assessment questions done, what they found was that although, and it was not a huge, assessment, they talked to about 140 people. They found that only 6% of those that responded had ever visited a mental health clinic in their life. But many people identified issues with depression, anxiety, and substance use in particular. So the Bienvenido program is developed as a mental health promotion program that is delivered in weekly sessions over a 9-week period. And they, they present information about mental health and available services, but they also really focus on, this question of collective healing, people talking and being together and feeling safe enough to discuss the distress they feel, not simply because of immigration issues, but marginalization in the community that they're feeling. And so these were some of the things that they did to help the program be successful. They start, they start those program sessions in locations that are already being used by the community. In this case, a literacy center. and facilitators are folks from the local community. As the program gets going, they also start to incorporate facilitators from past, program participants. These are some of the results that we see that Bienvenido saw as a result of their program implementation, right? They saw that the clinic itself sees an increase in its service use population by 124% over a 4-year period. So they end up having to increase their staff from 1 therapist who's bilingual, which was Gilberto, to 4. And then they hire a bilingual case manager, a nurse, and 2 administrative assistants, to their credit, right? Because they really responded to this outpouring of need. We also begin to see Bienvenido is getting a lot of attention from state policymakers and funders. They're funded and develop an adaptation of the program for adolescents. And they're asked to train others in 7 mental health centers around the state, as well as in organizations and churches around the country in 13 other states. So it really has grown quite a bit as a result. These are some of the larger community impacts that we found in the Community Defined Evidence Project that we thought were really also notable, right? A lot of the facilitators that worked with Gilberto, especially those original facilitators, go on and seek careers in mental health. And so we're seeing this, this sort of on-ramp to workforce that is desperately needed for Latinx and Hispanic communities. We also see that the former participants, as part of that effort to integrate into the community, they begin to work with local leaders and other officials to advocate for community issue in regard to community issues like immigration reform, and to fight against some of the anti-immigrant sentiments that were starting to really take hold in that state. And so in this way, they start to really, they create like a real world community of practice that is encouraging them to more broadly focus on local policies, service system policies, and state laws to support this broader community change. So just a few thoughts. I think I have, okay. So just a few thoughts about how I'm trying to apply these lessons learned in an evaluation where we are running a randomized control trial to test the effectiveness of peer support for families in child welfare. I won't go into a whole lot of it, but it is working with families that have had a child removed and placed in foster care. And the design of the study, although we have this trial that we're completing, we're also really focused on learning more about what families experience in the system, and really trying to move beyond. We're partnering with the local child welfare agency. They do a lot of the work in the evaluation in terms of randomizing families and helping us collect data, but then moving towards really understanding community level family experiences in the system, and how services, these efforts to change services and improve them ostensibly for their benefit. So I'm running out of time, but basically we collect a lot of qualitative data that we then share back with our stakeholders. We try to share with a group of families that has been that has been working as leaders to develop themselves as leaders and advocates in a system where they have never had a parent advocacy group. Okay, even though they've had foster parent and adoptive parent advocacy groups and formal associations with lobbying power. The final thing I'll just say is that we've been working really hard to apply some of these lessons from the community defined evidence in this project to really start to think about how we engage not just the provider partners, but really local people that are experiencing a lot of the inequities in communities in behavioral health, and which are serve as one of the major populations involved in child welfare. So I still, I encourage us to really think about these questions. Are we, as we are working together to have more equitable implementation, really overturning existing paradigms about research and researchers with communities, and really start to think about what questions do communities bring to the table that we can engage and partner with genuinely in order to learn more about what they want and what they need. Thank you.
Great, thank you. So now I think if the tech folks can help us bring Cheryl Boyce to the screen. This is the first time I've done a hybrid event, so I'm not sure how this goes.
Hello.
Oh, hello, Cheryl.
Hi, there I am. Hi.
Welcome. Take it away.
So we have till 12:30, I believe. Correct?
Yes.
So I'm pleased to be here virtually. I'm sorry I can't join you in person. And this is not my first Society for Prevention Research meeting. I've been attending it since I think I was a student. And I'm just going to share some thoughts on the priorities and strategies for implementation research from the federal side. And I will echo some of the wonderful thoughts from our previous presenters. And I'm really pleased to be on this panel with two outstanding implementation scientists who are considering equity, and just share some of the ways that we're thinking about equity at NIH, and to really inspire researchers and those in community research and community researchers themselves to think about how to do this and how to really be applying to NIH. And I hope some of these ideas translate to some of the other foundations and other agencies in terms of implementation science and equity. So I'm just going to go over a little bit of thinking about how we got here, and then implementation science and health equity. But I'll move fast because of time through some of the things that really have been covered so well by our other speakers, and then highlight the Common Funds efforts, which is where I've moved to since last year, to build some of the transformative research to address health disparities and advance health equity. So we've really moved in translational research over time, and I like to keep a list of how we keep moving along, from cells to society, cells to communities, from proof to practice to populations, from proof to prevention. There's really a way that we're just trying to really move science to practice faster and faster. And we often talk about this for this slide and these data that takes 17 years to turn only 14% of research to the benefit of patient care. But we must remember who were the patients this was based on. It wasn't very equitable, and it might even take longer for those, and they were left out of a lot of that data. So that odyssey probably is even more abysmal when it comes to diverse populations. And then most of us really think it's horrible that if only 18% of administrators and practitioners are using evidence-based practices, that's not so great either. And then when it comes to the populations, again, who are these populations in terms of equity? Who are we really talking about when we think of the science to practice that we've been moving, and we've been moving it pretty slow anyway. And the population that we have is increasingly diverse. And we think about our future generations under 18, that's increasingly diverse as well. So the world is changing, and we really need to consider what this is going to mean for health, and how can implementation science and how can preventative interventions really help us in terms of improving our health outcomes. Now, in terms of health equity, we're really trying to get that traction point right there in terms of translational science and implementation science, of translating what we know to the real world. And that is the world I live in. And I hope that's the world you live in as well. I've lived there forever. So I've always been interested in how we can really build, in my 2 decades at NIH, all that great knowledge and move it forward. And I've been there long enough to see so many great advances just haven't been moved forward. And I've been there over 17 years. So that data just doesn't move forward, and it doesn't move forward for many populations and among many communities. So when we look at the implementation pathway, I mean, the question I have, and I think Rachel brought this up a little bit as she adapted, which I really like that adaptation, is the implementation pathway really achieving health equity outcomes, or is it contributing to the disparities? And I think the kind of work that our two speakers speak about in terms of some of the practical applications of their work and working with communities, they're trying to make sure this pathway is achieving health equity through adaptations and the way they work with communities. And that's what we hope that prevention and some of the work that is done among those of you here in the audience and what you take back in your work will do. And the fact is that not enough of our evidence-based interventions really include social determinants. And all of the lack of diversity may be exacerbating health inequities. And as we know, most of our research has not been based on diverse population. So that really makes us question how we can improve things for the future. And the risk behaviors and exposures are shaped by not only the social determinants, but also these root causes of inequity, such as structural racism. And I like this look at the stream here, that there's a lot of things that we have to think about in terms of the upstream. And that has not usually been the type of research NIH has focused on in their initiatives. And when we think of health equity, it's not just giving everybody the same, but really tailoring, whether it be precision implementation and in terms of thinking about our efforts in terms of precision medicine, where we are worried about making sure that we don't leave people out who aren't going to academic health centers, but since most people come to their community for health. And it was nice to think about the anti-racism lens, but that is not what we have used in implementation research and the type of research that's funded at NIH. So that has been a great perspective for us to think about as we look at the research at NIH. So there is a new initiative, and it's called the NIH Unite Initiative, and that is focused on ending structural racism. And in support of that, I'm leading a transformative research program to address health disparities and advance health equity. And that's funded through the Common Fund. Many of you may not have heard of this, but they are the section of NIH that is transdisciplinary, transformative, cross-cutting across all of the NIH offices and centers in the Office of the Director. And that's unique, and it has the funding that really is for new catalytic types of ideas. And that is where this transformative health disparities research is happening. And the idea that is also supposed to foster this research among the other institutes and try to do some risky new types of things that will translate to the other institutes and centers. So we have funded our first batch of grants. We had 11 grants, and we just closed out an initiative that was only for minority serving institutions that were under-resourced. And that is new as well, to think about those who have not received NIH funding before. And it was to look at interventions that were health disparities, but making sure that they partnered and looked with communities at the research questions. So we funded our first 12 grants. We're now entering their second year, and we'll be funding a few more. They're getting ready for review. And just to highlight 2 grants, the Harlem Strong Mental Health Collaborative, they started out with a multi-sectoral coalition, but it's looking at community-wide collaborative care, looking with housing developments and primary care sites and CBOs. And then Eugenia South, who, if you ever want to hear her talk on NPR, it's wonderful, but it's looking at structural racism and actually going into the neighborhoods and thinking about financial services, but greening up the neighborhoods and greening up vacant lots and abandoning houses and remediating them, just getting into the neighborhoods practically, as well as thinking about the households and their financial needs and linking them to the types of services they need in terms of an intervention. This is not your typical NIH work. We're thinking about health outcomes. And then with Compass, and I'll end with that because we don't have much time. And Compass is a new effort that is going to test research partnerships that's community driven in terms of health equity structural interventions. And what's different about this is that instead of academics deciding to work with communities, communities are going to work with academics. They're going to devise the community-driven research questions, and then we're going to partner them with academics so that it will truly be community-driven. They'll get research hubs, health equity research hubs, to help them with their research projects. And then at the national level, we'll have a data center, clinical coordinating center, so that the typical evaluation and demonstration projects that often do not have the resources to make a national impact will have the multi-site data and the kind of rigor and reproducibility to make policy impact and national impact. And it's a 10-year initiative, and the last 3 years will be for sustainability and for policy impact. So it's a new way of doing business at NIH that we hope will be a model for future types of research community partnerships at NIH. And just to make sure that we think about how you're going to put in your proposal, there's always been some nice resources in terms of from Enola Proctor about your ingredients for implementation research. But it's really important to think about the feasibility, especially in this environment where things have changed in working with communities, and you have to be thoughtful about how to work in the environment and any possible risk, but it's still the feasibility and the approach. And here's another resource in terms of thinking about the D&I model and framework and the clear risk, and thinking about how you might deal with any kind of thing that might come up in a community. We have to be thoughtful and not only have a framework, but also think about how to make sure the different frameworks that were nicely presented before, and even a health equity framework, which came out last year, and how these might fit for your unique incidents, and how you might think about equity and how that might build into the framework you're using, whether you choose your framework that way or adapt it in terms of the question that you have, to really represent a thoughtful way of integrating health equity, as our other speakers so nicely integrated in their thoughts. And finally, I did want to make sure we talked about a lot of the resources that are available in terms of building out your models and thinking about implementation. And a lot of these are integrating equity, and also a resource that we did over 10 years ago, which was now it's available on most of our university websites as a free download from Springer. We had a text that looked at how to write grants, and their chapters to help you think through how you're going to approach your question. And I think at this time, we all are thinking about how to really integrate equity into our questions, into our implementation models, and hopefully into your future grants to NIH. And thinking about training, the National Cancer Institute has a wonderful training institute. And I think one of the best tools they have is that they have sample grants. And so as you think about your next implementation project and thinking about how to integrate health equity, I hope you remember this talk and our wonderful speakers. And as you go through the rest of the conference, think of your creative ideas and how to integrate health equity into implementation science and prevention. And with that, I think I'm out of time, if I'm correct, and I will turn it back over to our chair.
Great, thank you. So I know originally I said we didn't have time for questions, but Cheryl was so efficient that we do have time for questions. So I know there's a mic set up here in the front, and I would love if someone from the tech group can also let me know how we're going to handle the Q&A I see that is coming in on the Zoom room. That would be great. But if you do have questions, if you could come up to the mic, and the speakers would be happy to answer them.
Can you hear me okay through my mask?
Yes.
Okay. This is actually for Dr. Shelton. You mentioned that you have community identified evidence, community defined evidence. What does that look like, and how are you defining community defined evidence of successful implementation?
Yeah, sure. Can you hear me? So the way that we have thought about that is that they might not need to go through the translational pipeline, and how we typically think about, our efficacy trial, effectiveness trial, and then to implementation research. So community defined evidence might be something that's already being delivered. It might be developed by and for the community and is already being implemented, but maybe hasn't been rigorously evaluated. So that's how, an example is the Lay Health Advisor program that I talked about. That was developed and really created by the women in the program. It reflected their experiences of stigma and discrimination. That's why it was originally developed. It reflects, their values in terms of being women-centric and instilling kind of faith-based values into the curriculum. So that wasn't a researcher coming in and saying, this is what we're doing, let's develop and test this. That was really co-created by the women, and then they partnered with the researcher to evaluate it. And it's now one of NCI's evidence-based programs. So I think we often think about it as having to go through that narrow, rigid translation. And would just encourage people to think about practices and programs already being delivered that might have impact that just hasn't been evaluated. And I think your example was an amazing example of that as well.
I don't know, Linda, do you want to add anything to that?
No, I think that's, spot on. The Bienvenido program is an example of that. All of the practices, most of the practices that we looked at in the community defined evidence project haven't undergone rigorous evaluation. And some of the organizations and sites were very adamant that they didn't want to do that, right? They had a very clear political stance that they did not want to do that and didn't want to implement evidence-based practices for a variety of different reasons. So I think that there are some tensions and questions there that we have to kind of examine and contend with as researchers and funders and policymakers in terms of how we value what communities say they want and need as well.
Thanks.
I'll say one other thing related to that is one challenge that we've had is what does it look like when the evidence base changes over time? And that was the piece that I alluded to. Often we think about adaptations as related to kind of context and fit, but as the evidence changes, what's happened with this group is that it's no longer recommended that they do breast self-exam. And that was a real tension because a lot of the women, the survivors in the program, discovered their own cancers. It's a foundation, it's a core part of the program. So we have really negotiated and thought about, how do they keep this evidence base while still keeping that component that is of such value to them, particularly because they're at greater risk. And so they reframed it to the funders really as this is an empowerment and education tool that is critical to facilitate discussion and communication with providers and women in this community being familiar with changes in their bodies. And we're not using it as a screening tool. We're not, so that's kind of how they clarified that. But again, when you just look at it on paper descriptively, it looks like, they're delivering something that's not what we think about as evidence-based. So it's really had me reflect on kind of weighing the pros and cons of that, how we approach that evidence-based as it changes. And again, this issue of who is something, who are the guidelines evidence-based for?
And Rachel, I don't know, can you hear me?
Yes.
Oh, okay.
Very.
Okay. So I hope you just looking at my big face, but I guess you are. But in terms of that, I think the one thing that I do worry about with our implementation models in terms of equity and thinking about communities is, and you spoke a little, I saw that you spoke a little bit about in terms of de-implementation. When we come into a community and we are even thinking about any intervention, that we're not talking about, that we're often de-implementing something that communities value. And if we're bringing in an evidence base, it may not have any evidence, but there are community values that we are, that we're going to be changing, and we're really de-implementing maybe something that doesn't have any evidence, but it's something that they value. And the model doesn't account for that necessarily, but that's what we're going to be doing. We're changing behavior. It's a behavior change, but it's also a value change, and often something that's important to communities. And that's something I've always wanted to put somewhere in the model and in some kind of way. I think some of the needs assessment and qualitative data gets at that, but I don't know if you'd like to speak to that, but it's something that I think needs to be built more into our research process so that we can account for that. I think sometimes when we do adaptations and cultural adaptations, of course we need to measure and how we do that, but that will be important going forward as we work with populations and want to see effective change and sustainable change.
Great, thank you. I'm wondering if someone on the Confex could read some of the questions that came in. I want to acknowledge the online questions as well. Why don't you come up while they're figuring that out?
Thanks, lucky me. Could you talk a little bit about when you were coding those 240 interviews, just the process of it? Like, did you code as you went? Were there also archival documents, or was everyone just able to explain the program?
So these are great questions, and everyone wasn't, it's kind of like that picture of the elephant where everybody's touching the elephant and saying what part of the elephant, and in a lot of ways the providers, especially if they were involved in the development of the program themselves, they had a clear picture of what the intervention was, particularly in a formal way. I think service users were much more talked about the things that were important to them that made them feel comfortable coming to that organization or working with that provider and being part of that program. We coded using, like thematic analysis, and I had a team working with me because there was no way to do that in the amount of time that we really needed to. So the first thing that was clearly evident were the organizational practices that support the implementation, which was interesting, right, of these interventions. And then the next phase of that, once we got those out of the way and kind of reported those back to the National Latino Behavioral Health Association, the Casey Foundation, and SAMHSA, we really started to dig deep in terms of those essential elements. What were the core, components of these interventions that were so vastly different? And we had, like I said, we had drumming practices, we had some evidence-based adaptations, practice adaptations, and then we had like a couple of promotores de salud and engagement practices that really focused on this affirmation of identity, but also worked in terms of intimate partner violence spaces. So it was very interesting, collection of interventions. And it was a tough, I will say, it was a tough process. It's always tough to code and analyze that many interviews, right? That's a huge amount of interviews. And we had to take it piece by piece. And we actually left out one site because it was not a true sort of intervention or program. It was much more of this larger public awareness campaign. So that helped a little bit reduce our interview sample, but that's pretty much the way we did. And then we categorized based on what we were finding in terms of the interventions and the implementation factors.
We do have I can read the question from the Q&A.
Oh, that would be great, Cheryl. Thank you.
Yes. And I actually know who this is from. So it's a pleasure. It's one of my former fellows. And I live and work at a university in a state where the political climate makes it extremely difficult, if not close to impossible, to teach and do work related to structural racism. Do the presenters have any advice on how to do this important work in challenging political climates?
I mean, I work and teach in Florida, where we are either passed the law. I don't really pay attention so I can do my job, but the critical race theory type of thing. I teach a cultural competence and health equity course where I go in great depth about structural racism and the history of it in this country and in the Americas and how that affects and underlies the behavioral health inequities that we see. I haven't been run out of the university, but I really try to just stick with, facts that are demonstrable, pull in a lot of literature and research and just kind of present it in that way. I know that that's not a great answer, but I think that, it's what I feel I can do. And I know that in other states, it's getting increasingly more difficult, right? And sometimes I teach and then I say, okay, is this the day where I'm going to be, singled out for some sort of punitive measure? And thankfully it hasn't, but really that's what I try to do is stick to, literature, research, and present that back to the students. And I think the program that I teach in is really for behavioral health practitioners and professionals. So people have not really pushed back or said they were offended by anything they had to learn in the class. I think that there is a lot of difficulty engaging with some of these, this idea of structural racism underlying so much of the way we do things in this country. But other than that, I haven't, yet experienced someone just lose their mind in my class. So that's a good thing. Thanks.
And I think you can see that with Unite at NIH and the actual some of the work in the current RFAs. There are actually things called requests for information. There's one that's out right now from NIDDK, and there's several others that have come out where you can put in public record at the federal level thoughts, and those will create research opportunities, and they're existing. You can put it in for any of the existing investigator-initiated opportunities to study structural racism and make sure there's increasingly more data in terms of research, and that sticking to the research, I think, is great and an important way to handle it, and to handle it in terms of data-driven research papers. And I think the group that Rachel spoke about, and having maybe a study group or creating some peers and academic peers where you can talk about it and build theory and create models and a series of papers at your institution could be valuable. And that's, I think, an important part of surviving if you're feeling that it's difficult to get other scholars to work with.
One other, oh, sorry.
No, go ahead.
One other thought I had is, Derek Griffith, who's the senior author on that, we often have this discussion about sometimes people think with structural racism that it's kind of all or nothing, and they're a little bit like frozen with not knowing how to address it in their work or at their institution. And so we often think about it as that's one piece of it, but also really being clear about the downstream effects of it and how it's manifesting. Like, I think the example of the institutional pragmatic trial in North Carolina is a great example of that. That trial was really tracking the ways through which racial inequities were operating, which was impacted by structural racism. But they were really focusing on it in a very pragmatic, clear way about how it was operating. And there's great examples of, trauma-informed care, structural competency, other types of approaches, that are addressing, again, some of the downstream impacts of structural racism. So I think we have to think about it as kind of a multi-pronged approach in our work as well. So, yeah.
Yeah, I was just going to add, at the William T. Grant Foundation, we've been talking to a lot of our grantees that are also facing similar backlash, and thinking, and one of the clear messages we heard was also the need for researchers to continue to support each other, specifically around this issue of the racial backlash and what it means for research. And so finding ways to continue to provide that level of support will also be important.
There's a great review that I think, if I can share my slides, I'm happy to do, that came out on what is needed to implement anti-racist interventions in healthcare institutions. And some of the key findings probably aren't surprising, but they are things about the importance of leadership to speak up and to support this work, and for there to be resources and evaluation so that there's accountability. Those were three of the biggest factors. So again, those windows of opportunities where we can get leaders in who can support this work and vocalize its support and put funds towards it is critical as well.
Thanks. Do you have a question?
Linda, I was interested in the bullet about the use of the Boyce memos
Yes.
to do ethnographic kind of observations by the interventionists. Could you tell a little bit more about the goals of that and how it worked?
How we use the voice memos. Thanks,
Yeah.
Eric. Good to see you. We have the peer specialists, the parent partners in our project, record reflections on their phones after they work with families every time. And we did it for a period of about a year and managed to do that over the course of when the pandemic started. The idea behind that was to collect from them just reflections on their work on providing care and support to families. And we captured a lot of information, not just about what they need for support, which we know that, peer workers, community health workers, they really need a lot of support given, especially these peer workers that have lived experience with mental health, substance use, and prior child welfare experience. But we also captured a lot of their their effective, emotional responses to that work, the challenges, the real challenges that families face trying to meet reunification requirements. And then we captured a lot of the sort of chaos at the onset of the pandemic. And so we use some of those in a paper on just a quick rapid assessment of the pandemic and its effects on families in foster care. But we think that we're reflecting on that and writing up a paper on using that method to help us really capture ethnographic insights that myself as an ethnographer I can't be everywhere, and they're actually capturing that information for us and helping us to make sense of what they see, and then helping us to make sense of the project in terms of what families experience on the day-to-day. Good answer. Thanks.
Cheryl, is there another question online?
Yes, the other question is just about substance abuse. And it can be challenging when communities suggest that something is counterproductive in substance misuse prevention. Any thoughts to negotiate this? I know that we're not specifically targeting substance abuse, but just in terms of, I think some of the same things in terms of sticking with the data, even though it may be legal, some forms of substances may be legal, sticking with the data in terms of the question and the harm, I think is important in terms of your question. And in terms of specifically adolescents, it's an important variable. If you're studying the age range where use is a variable, I think it's important to be measuring it and be thinking about how it might fit into your overall question. So I think that's the comment I would have. And I don't know if the presenters want to add, but if I know that we have online some that are on some of the people from NIDA who might be able to be a resource in terms of thinking about those questions that you can always contact at the National Institute on Drug Abuse and other resources at NIH in terms of how we help those who are researchers deal with these questions.
Great, thanks. Well, I'll take the moderator's prerogative to ask the last question, which is that the more that I've been having conversations with people about centering equity in implementation as well as program development and sustainment, the question comes up about what funders need to do differently. And I am a funder, so I take this on myself as well. What funders need to do differently to think about doing this work differently, because the existing models may or may not always support this kind of work. So I wonder if both Rachel and Linda could reflect on that and share some piece of recommendations.
Sure. I love seeing what Cheryl presented. That gives me great hope, because I do think we have never seen calls for addressing structural racism or thinking about naming that. And so that's, to me, really important, the language of those, that they're acknowledging those and that they're saying they're going to put funds towards studying that. I think shifting the model in terms of the supporting the community partnerships and the engagement is critical. I have community partners who would love to be co-leads. We negotiate everything from resource sharing to roles and responsibilities, but it's hard to do with the way that the grants are set up. It is not community friendly, and it's not friendly towards long-term engagement. We've partnered for 12 years, but we had a grant for 3 years. We had a 5-year gap now, and so it's very hard, like building that trust and trustworthiness requires that they're at the table and have the resources and the input on the decision-making and the grants. And I think that we need to create more structures for funding. I think COVID RAD Act started to do some of that, where the resources were a little more equitably distributed, and we start to see the expectation for community input and accountability. But I think that, that's one example. And I think that we need more of those types of examples to support that.
Yeah, I don't have a lot of answers, but I know that, I'm currently working on 2 different projects with, foundations that are promoting community engaged work. One, our WJF focused project that is really, we're partnering with a community agency that is working with folks that have been formerly incarcerated and don't have access to healthcare as a result. And that requires sort of a sea change in terms of allowing them to take the lead in terms of formulation of the questions and what the methods are going to look like, and they're going to help us collect data. and really almost taking a back seat. And so I think, that has a lot of implications as for what Rachel was talking about in terms of how funders look at that picture and really make an effort to support the community. This question of like these, time limited projects and sustainability across time, having communities understand that is really difficult, right? And the smaller, and then the other project that I have is like $20,000 for a kind of a similar project, very small amount. So, we could then take, and this is with child welfare involved families, to do a participatory action research on the work that they're doing as leaders. So how do we then take that? I think a lot of this is translating back to the funding community and to policymakers, as opposed to translating, to communities, our research findings. And I really don't know what to say in that regard, but just taking some of those experiences and then trying to push that information back sort of upstream to the powers that be to help, change the landscape further.
Thanks. Cheryl, do you want the last word?
What you're saying is exactly on target. I think the dream would be, and I think when we had listening sessions and it was important and to hear from the community, and we had people I'd never heard from before and different kind of community organizations. And that is what NIH is trying to do more of. And in the end, it's not that overnight they wanted to get a PhD in research, they wanted to be equitable partners. And I think my dream would be to see communities come in. We have multiple PI status, and why couldn't a community be a multiple PI? And the reason is that right now, even though it would be officially allowed, our review system, so many of our systems are not set up for that. And so we have to show the data, and that's what this project would be, to show the data that they are viable and that the partnership would work. And that's what we'll have to do. And I think other funders may have more flexibility in doing those types of things, and hopefully they will. But equity means that they have what they need to be able to be a research partner, and we haven't set up our system to make it that way. So I do hope that we will continue to build out equity in all aspects of research in terms of review and the types of reviewers. NIMH does have community reviewers, but the rest of NIH does not. So we know there are ways to do this, and I look forward to things changing and to see the continual types of work that everyone's doing to build out equity in science.
Thanks. Looks like we have one last question.
No, it's not a question. It was just to add to this is publication process. It's, if funders could give us money to publish more quickly, because if we're doing these community partners and it's more descriptive paper and it's like, it didn't work because of all these reasons, it's very hard to get that published and very quickly to let others know. So I think that would be another thing I would add. Thank you.
Thanks. Well, I want to thank the panel for this wonderful kickoff to our SPR meeting.